You may or may not know, but you know now that a grant was put in for the Right Care Initiative here in San Diego to help support the work that we're doing, the University of Best Practice, the patient activation, and help build an infrastructure to help keep the Right Care Initiative going on. And I must thank Liz. Liz.
She's out shepherding the doctors doing our
Okay, so Liz is one of the persons who helped really get that grant organized. Hattie, Warren, and Alan. So they're all gone. Where's Alan? Alan, who did a tremendous amount of work. And again, thank you for putting that grant across our fingers that we and so I did mention the one-year anniversary when you were out. And then maybe we'll go around real quick and just do introductions again. I think most people know each other, but just in case. And we have a few special guests here that I'll let them introduce themselves. Tony? Elizabeth, I'll introduce you in a second. Maybe Jim?
Jim Dudley, Kaiser for Intake.
Gerardo Moreno, UCLA Medical Group.
Alan Kimon.
Greg Garner, Sharp Community Medical Group.
Fritz Steen, Artel Partners.
Sandy Garibaldi from Navy Medical Center, San Diego.
Hi, Michael Pollock, Rady School of Medicine.
Warren Bryan, UC Berkeley School of Public Health.
Lynn Farrell, Council Community Clinics.
Paul Hernandez, I work with Cinemed and Director of Multicultural IT.
Sandy Moore, with Cinemed and Multicultural.
Onagashi, I work for Ralph's Pharmacy. And lead clinical coordinator for Ralph's Pharmacy. Shirley, UCLA Medical Group.
I'm Kaiser San Diego. Ray Bocketing, Kaiser here in San Diego.
Scott Flint, Artel Partners.
Christian Payne, call Dr. Medical Group.
Marilyn Levy, Artel Partners.
Jonah replied from the Karolinska in Sweden.
And Bob Kaplan from the National Institutes of Health.
How do you have it?
So I'm Tony DeMaria, and I just want everybody to relax and know that I did not take offense that Dr. Penso eliminated me from my efforts on the grant. No offense whatsoever. However, I would like to tell you that about a week ago, because the people at the CDC had heard of activities like this, the University of Best Practices and our Be There campaign to eliminate heart attacks and strokes in San Diego, they are having a special CDC grant round on the Million Hearts program in Atlanta. And I will be flying there to represent you to present at that grand round. So your fame is spreading. Your fame is spreading. And no offense.
And Tony, thank you. And thank you to Tony, Jim, to again, people who helped spearhead writing this grant and getting it moving forward. So again, our fingers are crossed that the grant comes through. But even if it doesn't, I think the work that was put in will be helpful as we go forward to get us organized and thinking about how to build this going forward and keeping it going strong. So,
Jerry, what are the timelines on the grant?
Liz,
April. It's
March
31st.
March 30th, we find out.
Yeah, April the 1st.
Good.
March 30th, that stands corrected.
And
Thanks.
Bob, would you like to just say a few words and welcome as one of our, let's say, our founding father.
Well, listen, it's a pleasure to be here. I'm Bob Kaplan. I was formerly at UCLA and UCSD before that, and I have to say I'm a newbie at the United. Actually, I've been there a year, believe it or not. I just finished my year in this year, and it's a pleasure to be back and see everybody and just see the project moving along. Just looking forward to learning how things are going.
Welcome. I'm going to go ahead and introduce our speaker, and if people remember the format, the speaker will be presenting for about an hour, and then we'll break up into small groups, discuss what we learned, see how we might want to apply it to our own organizations, and then come back and report out. And my promise, as usual, is to get us out on time, so by 2:30 can get back to your other duties. So I'm very pleased to introduce Elizabeth Oyekan, I got that right, who was recommended by Jim Duddle from Kaiser. So she's here, and again, most of the speakers we bring here are from recommendations from the group because they go, yes, this is the type of thing that will help us succeed. She is National Pharmacy Quality Medication and Patient Safety Leader for Kaiser Permanente, and also the Southern California Co-Leader for Outpatient Pharmacy Clinical Services and Medication Adherence Steering Committee. She has contributed to the appropriate medication use and adherence in patients with chronic conditions, both within and outside Kaiser Permanente, and author of the Be Smart Handbook, which you'll hear more about, a provider guide with interactive modules. So again, I think you'll find this very valuable, and welcome Elizabeth.
Thank you. Okay, good afternoon, everyone. Good afternoon. Okay, I know your mouth are full, but yeah, after that you say good afternoon. Thank you very much again, and it's an honor to be here to present to you. Over the last 10 years, I've had the incredible privilege of working with patients, with staff members, with leaders from the physician group, pharmacy group, nursing group, both within Kaiser and outside of Kaiser, to really begin to try and figure out how do we address this issue of medication adherence. And it all started actually when I was at a medical center, and I was the population care management director at one of our medical centers. And one of the things we realized was all of a sudden, with our HEDIS measures around diabetes care, dyslipidemia, we just plateaued. And no matter what we did, nothing seemed to move it. And so one of the things that the physicians and I did is we started looking at a lot of our patients, and one of the things we realized very quickly is, well, we did an incredible job of starting patients on the right medications. When we started looking at them 6-9 months down the line, we started to notice that more than 50% of them either were not on the medications or not taking them as prescribed. And so we started an initiative at that point in time to really begin to see not only how do we put patients on medications, but how do we keep them on medications. And so one of the things I'd like to do today is share with you a tool that we've used, but initially what I'll do very quickly is do a broad overview of medication adherence, and then go into some of the specific things that we've done in order to try and improve the health of our general population, to improve the care that we provide to individual members, and then hopefully to reduce the overall cost per capita. So,
what was that number? What percentage were not taking the medicine?
over 50% we're not. Over 50% we're not taking it as the physician had recommended.
Did you publish that somewhere?
Actually, you know, one of the things is we're going to start publishing. No, we don't, because in Kaiser, at least in pharmacy, we just not taking the time to do a lot of publications. But this year, we're going to have about 4 different publications coming up around that type of information. Yes?
There's actually Cochrane review on medication
Actually, yes.
specifically about antihypertensives, and a couple of years ago, the medication adherence rate was about 15, or lower.
Thank you, Grace. So
And
Grace
actually-
just gave us a source for that. Right, and actually I have also here, you'll see from the AT Carney studies that show for different disease conditions and the adherence rates. So we'll go through that. Okay, so let's take a look at the whole issue of medication and adherence from the point of view from one of our patients. This is MT, he's a 62-year-old gentleman who has a history of diabetes, CAD, uncontrolled hypertension, smokes 1 pack of cigarettes per day, and he's about 25 pounds overweight. One day as he was driving home from work, he started feeling some tingling down his arm, and then drove himself to the emergency room where he was diagnosed as having a mild heart attack, and then was admitted to the hospital, discharged 3 days later, and then was scheduled to see his primary care physician 5 days after that. Amongst all his different labs, I just pulled out a few of them here that shows that his hemoglobin A1C for his diabetes was 9.2, his LDL was 162, and his blood pressure was 146/92. And I think, as you can see, none of them were in control. Upon doing a medication review, these are some of the things that his physician found out. He was on metformin 1,000 milligrams a day. And one of the things that we tell patients to do, especially in our pharmacy, is always associate your medications with an activity that you do so that you will remember to take that medication on a regular basis. Well, guess what he decided to do? He decided to associate it with when he gets up in the morning. So he took 1,000 milligrams of metformin on an empty stomach, and the result of that was stomachache and diarrhea. And so what he did is he arbitrarily cut that dose in half. The other thing was his evening dose. He said, you know what? The reality is, after the hustle and bustle of the day, I don't remember whether or not I took my medication in the evening. Another thing was with his hypertension medications. He said, you know what, it made him feel dizzy and nauseous, so he would take it whenever he really felt he needed to, but he didn't take it every day. His beta blocker medication, he said it made him feel tired, so he actually stopped taking it. He also felt he was on too many medications because he was on 11 medications, and this was a way also for him to reduce the number of medications that he was taking. And what I've just presented to you here, I think for you in practice, this is not unique. This is something that happens with a number of our patients on a day-to-day basis. And this is why a lot of them do not get the benefits that they want from their medications. These are just some statistics here. It says 1 out of 8 patients who have a heart attack will stop taking their life-saving medications just within 1 month of that episode. 15 to 31% of prescriptions are not filled the first time around. It's usually actually about 12 to 15%. However, with the advent of the electronic medical record, I will explain to you what has happened now that has significantly bumped up the number of patients not going to get their medications. And then also, as I mentioned earlier, and actually this is also from the CDC, is that 1 out of 2 prescriptions are not taken as directed. And in 2005, 3.8 billion prescriptions were filled in the United States, and approximately 1.9 were not taken as prescribed. If you take a look at adherence by disease states, you can see from dyslipidemia to depression, hypertension, obesity, you can see 3 months, 6 months, and 12 months. You see a decline in patients not taking their medication. And this comes from Medco as well as A.T. Kearney that did multiple studies looking at patients' adherence rate over time. So what is the impact of them not taking their medications? One of the biggest impacts is a decrease in population health. First of all, we see that population health is decreased because there's increased hospitalization and nursing home admissions. When we look at preventable hospital admissions, 10 to 15% of preventable admissions are from patients not taking their medications as prescribed.
That's amazing.
1 out of 5 patients in a nursing home is in a nursing home because of non-adherence. And if you want the citations, I can get those for you. And then if you take a look at this, if you take a look at the bottom here, what these bars show you is that as patients become more adherent to their medications, whether it's a heart failure patient, diabetes, hypertension, or dyslipidemia type patient, their hospital risk goes down as their adherence increases. The other thing we've seen also is that with non-adherence is that we've seen an increase in progression of disease. So you take a look at patients with beta blockers, post-MI patients on beta blockers. What we've seen is that patients who are not about 70 to 80% adherent to their medications have a 4.5 times increase in mortality and morbidity. Patients on tamoxifen for cancer, for breast cancer, if they're not on that medication about 90% of the time, there's a reduction in mortality, there's a increase in mortality and morbidity for them within a 5-year span. And then also, if you take a look at patients on hypertension medications, if they're not taking their medications as prescribed, there is increased chances of them having heart failure, kidney disease, as well as other complications. Also, according to the CDC in 2002, when they took a look at medication non-adherence, it was estimated that about 125,000 patients died from not using their medications as prescribed. And if that was translated into a disease state, it would be considered the 4th leading cause of death in the United States, behind heart attack, cancer, and stroke. And so now we're really, with all the data that's out there, and as we begin to bring it together, we're now really seeing the gravity and the impact of medication non-adherence. There's also increase in cost per capita, and this actually came from one of our Kaiser Permanente regions. Taking a look at patients with coronary artery disease before a heart attack episode and after, and just seeing the cost to take care of that patient. Before the episode the patient had, $2,800 is what it costs to take care of that patient. After the episode, it's over $10,000 that it is. So again, a major impact on our healthcare system. Looking at employer groups, for every $10 an employer group spends on claims for a patient, pretty much 1 out of those $10 is being wasted due to patients not taking their medications as prescribed. And so in the literature, you will see data that shows that anywhere from 177 to $290 billion are spent on addressing the issue of non-adherence, whether it is direct or indirect cost. This here also just shows you a diabetic patient, diabetic population. And what it shows is that on your left-hand side are patients who are non-adherent all the way to patients who are. They spend about $55 annually on their medications, but look at their total healthcare cost. This takes into account ED visits, hospitalizations, as well as doctor office visits. And it shows that the patient who is non-adherent, while they may spend a lot less on their medications, they cost the healthcare system more than twice as much as a patient who is adherent, at least 80% adherent on their medications. The other good news now that we have is that we now have evidence that actually does show that when patients do take their medications correctly, that there's actually positive